Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in International Medical Congress of Silesia 2025. My name is Piotr Ziobro, and it's my pleasure to coordinate the cardiac surgery session. And I would like to welcome esteemed jury, and I would like to explain the rules of the session. The order of presentation will be the same as in an extract book. The maximal time for presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on to the conclusion and finish the presentation as soon as possible. And a few words to the esteemed jury. I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number of your card. Other members of the same clinic are able to assess the presentation. The assessment will be verified. We kindly ask the jury to assess. The first point is the scientific value from 1 to 5 points, way of presenting from 1 to 5 points, discussion from 1 to 5 points, and own contribution from 1 also to 5 points. And when the session ends, we will send these cards back to you. So thank you very much, and let's begin with the first presentation of the day. So let's begin with the first presentation. The name is Untitled Cardioverter Defibrillator Longevity Comparison of Predicted and Observed Data. Thank you.
Hello everyone, dear esteemed jury. My name is Natalia Kwaśniewska and I'm a fourth-year medical student from Medical University of Silesia, and I would like to present our research evaluating implantable cardioverter defibrillator longevity, comparison of predicted and observed data. Let me start with a short clinical background. Implantable cardioverter defibrillators are used for both primary and secondary prevention of sudden cardiac death. We divide them into single and dual chamber devices. Single chamber ICDs have right ventricular lead with coil and are used for defibrillation, cardioversion, anti-tachycardia pacing, and VVI pacing. Dual chamber ICDs have right ventricular lead with coil, but they also have right atrial lead. They are used for bradycardia detection, and because of that, they have additional DDD pacing. They are also diagnostic for supraventricular arrhythmias, especially atrial fibrillation. The battery depletion is determined by the number of interventions, high energy shocks, and ATPs, the percentage of pacing and recharging of capacitors. The aim of our study was simple: to evaluate battery longevity in the ICDs within a real-world clinical setting and compare it to manufacturer's data. It was a single-center retrospective study of consecutive patients who underwent ICD replacement between January 2025 and February 2025. We included all adult patients who underwent ICD replacement regardless of the device's pacing mode and brand. Our only criterion was that the patients had previously implanted ICD that was now being replaced due to battery depletion. We extracted data both from the electronic medical records and device printouts obtained during the follow-up visits. Then we compared those data to official product performance reports. In total, we studied 119 patients. The majority of them, 103, had Medtronic ICDs, 14 had St. Jude ICDs, and 2 had Boston Scientific devices. Due to small number of St. Jude and Boston Scientific devices, our more detailed analysis focuses primarily on the Medtronic subgroup because they form the core of our study. When it comes to patients' characteristics, majority of the population, that is 72%, were male, 60% were implanted as secondary prevention, 7% had atrial fibrillation, whereas the rest of them had sinus rhythm. 75% of implanted devices were single-chamber ICDs. Sex distribution, heart rhythm, and type of implanted ICD distribution were all typical. However, in our study group, there was a high number of patients who were implanted as a secondary prevention. The mean age of the patients who were implanted with an ICD was 60 years old. However, patients who were implanted as a secondary prevention were older than those who were implanted as primary prevention. In the Medtronic subgroup, we analyzed a variety of parameters, like ventricular and atrial pacing burden, which was much higher in dual-chamber devices study group than in single-chamber group. The mean number of shocks, which was also higher in dual-chamber devices group because it was 1.8, and only 1.1 in single-chamber devices group. And the mean number of ATPs was a little bit higher in the single-chamber devices group because it was 3, and the mean number of ATPs for dual-chamber ICDs was 2. The mean battery lifespan of single-chamber ICDs from Medtronic was 9.2 years, and for dual-chamber ICDs, it was 7.5 years. The early depletion that is below 3 years didn't occur in any of the devices. Our results in both cases exceeded official projections from product performance reports. Here you can see the Kaplan-Meier curve of the device longevity from the devices of Medtronic. These dual-chamber devices had shorter lifespan than dual-chamber ones. And to summarize our study, highlights the strong long-term performance of Medtronic devices in real-world setting. Our results suggest that optimal patient care and individualized device programming can significantly extend ICD longevity, and device battery lifespan seems better than projected, especially in patients who are implanted with single-chamber ICDs and with low pacing requirements. Thank you very much for your attention.
Okay, so thank you very much for the presentation, and now is the time for discussion. Is anybody from the jury, when I'm talking to online, would like to ask some question about this presentation? Okay, if not, jeżeli mogłabyś powiedzieć, jaki był wkład twój w tą pracę? Nie, po polsku. Dyskusja, bo dyskusja może być tutaj po polsku. Jaki był wkład w twoją pracę i ogólnie, czy jest jakiś temat, który byś chciała jeszcze rozwinąć w tej pracy na dalsze?
Jeśli chodzi o mój wkład własny, to brałam udział w przede wszystkim kolekcjonowaniu tych danych wszystkich i później ich analizowaniu. Również brałam udział przy tworzeniu statystyki tej pracy i przygotowywaniu tej prezentacji. No i ją teraz wygłosiłam. Dziękuję bardzo.
Super, bardzo dziękujemy w takim razie i chciałbym przejść do następnej prezentacji, który tytuł jest Profile of Comorbidity and Surgical Risk in Patients Undergoing TEER Procedure. Please join me. Welcome.
Good afternoon, ladies and gentlemen, dear jury. My name is Marta Marks, and I'm a third-year medical student of Medical University of Silesia in Katowice and a member of SKN of the Third Cardiology Clinic. And I'm honored to present you results of our study assessing comorbidity and surgical risk in patients undergoing transcatheter edge-to-edge mitral valve repair. So here is my plan for this presentation. And firstly, I would like to talk about what we know about mitral regurgitation. So mitral valve regurgitation is a common type of heart valve disease. In this condition, the valve between the left heart chambers doesn't close fully, and the blood leaks backwards across the valve. If the leakage is severe, not enough blood moves through the heart to the rest of the body, and it induces symptoms like fatigue, like arrhythmia, shortness of breath, especially when lying down, palpitations, swollen feet, or ankles. And cardiac surgery is a preferred method of this disease treatment, but nowadays we also have an alternative, something called transcatheter edge-to-edge repair, in short TEER. Nie działa. Okay, so TEER is a minimally invasive and less aggravating than surgery method of valve treatment. And moving on to the aim of our study, it was to assess comorbidity and surgical risk among patients undergoing TEER. As for materials and methods, it is a retrospective study conducted from August 2022 to March 2025. And we collected data from medical history of patients, also laboratory results, echocardiography data, and then we assessed the risk of cardiac surgeries using Euroscore 2. So in our database, there were 88 people with the mean age of 77.1 years. 52% out of the whole study group were men, and the most common comorbidities included hypertension, atrial fibrillation, coronary artery disease, chronic kidney disease, and diabetes. The mean ejection fraction was 42%, and the most of our patients had NYHA score 3. The mean of coexisting diseases was 8.7 per patient, and the mean of taken medication was 10.2 per patient. As I said earlier, we used Euroscore 2 to assess the risk of cardiac surgery for those patients, and the mean score was 6.24%. But as you can see, most of our patients had scores from 1 to 7%. So we asked ourselves, what impacts Euroscore 2? Maybe it is age, or maybe it is gender, maybe it is myocardial infarction, or coronary artery disease, or PCI, or hypertension, but actually it's none of those. We performed a statistical analysis, and it hasn't showed any correlation between those factors and an impact on Euroscore. But the most significant impact had previous cardiothoracic surgery, which increased the surgical risk over 4 times. Then also chronic kidney disease had an impact. It increased the surgical risk over 2 times. And also diabetes increased Euroscore 2, but here it doesn't matter if it's insulin dependent or non-dependent. Both of them increased the surgical risk about 1.5 times. It's important to mention that during our study there were no intra-hospital major adverse cardiovascular events such as death, stroke, myocardial infarction. And I want to highlight that Euroscore was 6.24%, so statistically 5 people should have died, but actually none of them did. And now moving on to conclusions, this study shows that despite multiple comorbidity and high preoperative risk, minimally invasive methods such as TEER are beneficial and safe alternative for cardiac surgery in a selected group of patients. Thank you for your attention and feel free to ask questions.
Super, very thank you. No i teraz przejdźmy do, it's time to proceed to the discussion. Czy są jakieś pytania? Również tutaj do pana, czy pan profesor może ma pytanie i pozostała część?
Tej pracy bardzo ciekawa i zresztą pięknie powiedziana, ponieważ istnieje prawdopodobieństwo, że pani tę pracę będzie jeszcze wygłaszać, to chciałbym może tak bardzo krótko, żeby nie przeciągać tej rozmowy, spróbować zwrócić pani uwagę na pewne fakty. Mianowicie w tej prezentacji bardzo mocno pani się skupiła na tym, jakie elementy Euroscore'u, jaka jest kontrybucja poszczególnych elementów Euroscore'u na jakby totalną wartość punktacji. Ale to jest wiadome. I obojętnie, czy pani tam włoży mitraclip, czy pani tam włoży bypassy, czy cokolwiek innego, ta skala jest znana. Czyli jak gdyby analizowanie tego, że zwiększenie ryzyka wynika z faktury operacji, będzie takie samo dla mitraclipu, dla bypassów, dla czegokolwiek innego, prawda?
Tak, jak najbardziej, tylko tu też chcieliśmy zwrócić uwagę, jakby co najbardziej po prostu wpływa na ten Euroscore, no bo jakby w tym kalkulatorze jest dużo tych czynników.
Zgadza się. Tak, ale jakby warto jakby tak bardzo subtelnie, może nie eksponować tego aż tak bardzo, bo prezentacja gdyby nie dotyczy Euroscore'u, tylko mitraclipów. Pani w prezentacji ma leki przyjmowane 10,2, to znaczy, jak pani to rozumie? Czy tam
to znaczy,
10
to była średnia i tam tych leków było...
Na to chciałem zwrócić uwagę, bo pojęcie przyjmowania lub nieprzyjmowania leków nie może mieć wartości ułamkowej, prawda? Tak jak klasa Nycha nie może mieć wartości ułamkowej. To jest zmienna, która jest zmienną kategorialną. W związku z czym nie może być opisywana za pomocą średniej. No nie może, po prostu. Nie można powiedzieć, że ktoś przyjmuje 3,2 leku, nie? Albo 3, albo 4. I wydaje mi się, że konkluzja, że 6 osób z tej grupy powinno umrzeć, znaczy mogłoby umrzeć, jak gdyby, co by miało wynikać z Euroscore'u, no byłaby adekwatna, gdyby ci chorzy byli leczeni chirurgicznie. Ta skala służy do oceny ryzyka chirurgicznego. My nie mamy odpowiednika skali Euroscore do oceny ryzyka okołooperacyjnego w przypadku zabiegu brzeg do brzegu. Więc nie możemy powiedzieć, że 6 z nich powinno umrzeć. Ja myślę, że to pani miała na myśli, że w przypadku, gdyby zabieg był wykonany metodą klasyczną, to ryzyko, że część z nich zginie, no, pozwalałoby szacować, że ilość tych osób byłaby około 6, prawda?
Tak, zgadza się. To był taki skrót myślowy po prostu.
No, tak myślę, warto to tak powiedzieć, bo to jest ciekawa praca, naprawdę. Tylko proszę przemyśleć pewne przesunięcie akcentów i naprawdę gratuluję. Bardzo mi się to podobało. Dziękuję bardzo.
Super, bardzo dziękujemy za prezentację, za tutaj refleksję pana profesora. I tak, czy jeszcze ktoś może z jury by miał jeszcze jakieś pytania? No jeżeli nie, to przejdziemy sobie do następnej prezentacji. And the next presentation is it's titled Pulmonary Route Geometry Variability During a Cardiac Cycle in Light of Catheter-Based Procedures. Tak, i tutaj łączymy się również przez platformę Zoom. Zapraszam serdecznie, oddaję głos i powodzenia. Dziękuję.
Good afternoon, my name is Adam Priyatka and I am a medical student representing the Department of Anatomy at Jagiellonian University Medical College. Today I'd like to briefly explore the topic behind the pulmonary route geometry variability throughout the cardiac cycle and its clinical significance in terms of modern catheter-based procedures. First of all, I would like to introduce some novel terminology describing pulmonary routes. So on the figure number 1, you can see the pulmonary route is described as a part of the right ventricular outflow tract supporting the pulmonary valve. limited proximally by the basal ring, which corresponds to the basal attachments of cusps, and limited distally by the sinotubular junction, which you can see on figure number 2. And it is a visible line that separates the pulmonary sinuses ends from the tubular construction of the pulmonary trunk, and the area enclosed within sinotubular junction corresponds to this tubular plane. And for the comparability of these measurements, we introduced 2 novel planes, namely CCP, which is a coaptation center plane, and it is a plane which is created by the most inferiorly lying points within commissures, which you can see on figure number 2, and the commissural plane, CP, which is a plane created by the most superiorly lying points within commissures. Next slide, please. And for the purpose of this work, we created a 3D blood pool reconstruction of CT angiography, and you can see it on this figure. And yeah, it was created for the better visualization of those planes that I mentioned previously. And you can see also the relations between adjacent structures. Next slide, please. And so the aim of the study was to assess and to quantify the geometric, morphometric, as well as the positional variability of the pulmonary route during cardiac cycle using contrast-enhanced ECG-gated CT angiography. Next slide. We screened a data set of consecutive CTA scans for the evaluation of coronary artery disease. We excluded those CTAs that had low quality images with motion artifacts, as well as through contrast in the pulmonary artery, or any implantable devices in the right heart chambers, or any non-structural heart disease. So we initially had revised 196 CTA scans, but after applying this criteria, we included 100 adult patients of mean age 59.5 years old, and 51 of them were female. And I also want to mention that all reconstructions, as well as the measurements, were created using the segmentation software called Minix. Next slide, please. For angular measurement methods, they were performed in 2 axes, sagittal and axial, using a line connecting centers of the basal ring and tubular plane, which you can see on those figures. Next slide. When it comes to planar dimensions as well as the area, we used semi-automatic methods by tracing the circumference of the cross sections in a multiplanar view, as shown in this example. And also you can see the output from the software in the left upper corner. Okay, next slide. And the cross-sectional areas were significantly larger in the systolic phase, except for the basal ring, which was larger during diastole. In the diastolic phase, the largest cross-sectional area was observed at the caudation center plane. In case of systolic plane, the largest cross-sectional area was also observed at the caudation center plane. The pulmonary root volume was higher in the systolic phase compared to the diastolic, and this is presumably attributed to the elongation of the pulmonary root during contraction. Among the 2 measured angulations, the sagittal angle was only differed significantly during both phases. Next slide, please. And to further emphasize these differences between each cross-sectional areas, we made a box and whisker plots. It also included additional data from our previous cadaver-based anatomical study on the same topic. But what I want to underline is that the basal ring demonstrates the greatest cross-sectional variability between systole and diastole, whereas the caudation center plane shows the least fluctuation. Next slide. We also utilize multi-phase reconstruction, which enabled us to quantify the pulmonary root movement during relative to the chest wall throughout the cardiac cycle. And this movement was assessed by measuring the displacement of the basal ring center points within a coordination system across different phases. And you can see that on these figures in oblique view and as well as sagittal view. And during this systole, the basal ring moved in a caudal, ventral, and leftward direction. And this displacement likely plays a role in the observed increase in sagittal angulation of the pulmonary trunk during systole. And next slide. So this CDA-based analysis demonstrates that the pulmonary root is a dynamic structure, exhibiting significant measurable changes in the geometry and position between systole and diastole. And it also constitutes a necessary point of reference for clinicians performing ablations in the pulmonary wall, so-called reverse U-curve technique, because its implementation requires insertion of catheter. As you can see on this figure from a study, the tip of catheter forms a U-shape while positioning within pulmonary sinus. And it's a technique that has a renewed interest due to increased incidence of idiopathic valvular ventricular arrhythmias occurring in this region. So clinicians should acknowledge the displacement of pulmonary root and its geometrical variability during the cardiac cycle, as this study showed. Thank you. And if you have any question, I will be pleased to answer them.
Thank you very much for your presentation. Is there any questions maybe from the jury? Czy są jakieś pytania? Można zadawać w tej dyskusji. To jeżeli nie ma tutaj żadnych pytań, mamy tutaj pytanie o Pana wkład własny w tą pracę, na czym on polegał i czy są jakieś perspektywy dalszej rozwoju tej pracy i tego tematu u Państwa?
Jeśli chodzi o mój wkład, to wraz z kolegą, którego był wspomniany na slajdzie tytułowym, przejrzeliśmy najpierw te obrazy i spośród nich wyselekcjonowaliśmy te, które uznaliśmy za słuszne w myśl kryteriów. I następnie zajęliśmy się właśnie segmentacją tych obrazów i rekonstrukcją i następnie wykonywanie pomiarów, które mieliśmy wykonać. No i później przeszliśmy do analizy statystycznej. To też się podzieliłem tym wkładem ze swoim kolegą. No i oczywiście na potrzeby tej konferencji przygotowałem prezentację i te zdjęcia, które widzieliście Państwo, również przygotowałem w własnym zakresie.
Okej, super. Bardzo dziękujemy w takim razie. Gratulujemy prezentacji. And now we would like to move on to the next presentation, and it's called The Total Acute Occlusion of the Left Main Stem to Retrospective Study Years from 2020 to 2024.
Good afternoon, ladies and gentlemen. My name is Natalia Zabawa, and today I have immense pleasure to present you the results of our retrospective work concerning the topic of total acute occlusion of left main stem. Let's start with what is already known to everyone, that the left coronary artery provides blood flow to over 2/3 of the heart muscle, particularly the left ventricle, which is responsible for generating the heart's contractile force. Consequently, its obstruction can lead to a significant impairment of cardiac function, which clinically present as an extensive myocardial infarction, deadly ventricular arrhythmias, cardiogenic shock, and extreme risk of death. These severe consequences are not surprising, considering the extent of myocardial infarction caused by total occlusion of left main stem, which is presented in the first photo. The second one, taken after successful PCI, shows a coronary flow that closely resembles the normal one, as presented in the first photo. Concerning that there is limited data regarding this topic, our study aimed to analyze clinical presentation, procedural data, and outcomes of patients with this disease. Thus, understanding of this condition could help improve treatment methods and consequently lead to a better prognosis for patients. Concerning that there is limited data regarding this important topic, we conducted a retrospective analysis of the register of PCI performed in a university hospital in Krakow between January 2020 and December 2024. Out of 2,510 emergency PCI, only 15 cases, which is 0.6%, involving total occlusion of left main stem. Mean age of this population was approximately 69 years, with males comprising 87% of this population. As we expected, most of them presented with classic cardiovascular risk factors, such as hypertension, 83%, smoking, 50%, and dyslipidemia, also 83%. Moreover, only fewer than half had a history of prior PCI or acute coronary syndrome, which limits the potential for early diagnosis of this disease before total occlusion occurred. Additionally, no correlation was observed between highly elevated levels of troponins or NT-proBNP and poor prognosis in this group. When comparing the disease, ST elevation myocardial infarction occurred more frequently in fatalities, whereas the incidence of STEMI and non-STEMI was similar in the survivors. Moreover, the analysis identified cardiogenic shock as well as prior sudden cardiac arrest as independent predictors of in-hospital mortality. The presence of an occluded left circumflex artery was observed in 70% of fatal cases. Moreover, a more adverse prognosis was likewise observed in cases involving occlusion of the distal segment of this artery. Moreover, achieving TIMI-free flow following PCI was observed in survivors, whereas no reflow following PCI was typically in fatal cases and occurred in 70% of these cases. The mechanical circulatory support in the form of ECMO was used only one, in the form of intra-aortic balloon pump into once, and an impeller device was used only once. Moreover, mean procedure duration was approximately 80 minutes, and this amount of minutes was similar in both of groups. Moreover, IVUS was used only in 5 patients, whereas OCT was not used even once. It's important to note that the actual mortality rate may be higher than reported, as our study did not include patients who died before reaching the hospital. It is possible that left coronary artery dominance, undocumented in our study, was present in some of these individuals, potentially contributing to fatal outcomes of these patients. Another essential consideration is the abilities of treatment methods. PCI is the current standard in treating cardiogenic shock complicated myocardial infarction, which is often present in cases of total acute occlusion of left main stem. Let's move to the conclusion. Although complete occlusion of left main coronary artery is a rare indication for emergency PCI, the need for urgent intervention to restore coronary perfusion presents a significant clinical challenge. The results shows after PCI that the survival following this disease remains low, with approximately half of patients being discharged alive, despite the successful restoration of coronary flow equal to TIMI2 or 3. Thanks for attention. It was a pleasure to present you the results of our work.
Thank you very much for your presentation. Bardzo dziękujemy za prezentację. Chcielibyśmy teraz przejść do dyskusji. Czy ktoś z komisji z jury ma tutaj pytanie ewentualne, to prosimy bardzo. Może pan profesor ma jakieś pytanie ewentualnie? Dobra, jeżeli nie ma pytań, to chciałbym się zapytać również tutaj za każdym razem, jaki był twój wkład własny w tą pracę i czy są jakieś perspektywy dalszego rozwoju w tym temacie?
No to zaczęłyśmy od przeglądnięcia, w ogóle znalezienia tych przypadków, bo jest to rzadkie zjawisko, jak to podkreśliłam. No i z 2000 przeanalizowanych przypadków tylko 15 z nich okazało się tą całkowitą okluzją. No i przeanalizowałyśmy te wszystkie przypadki, zrobiłyśmy analizę statystyczną, no i przygotowałam właśnie z koleżanką, współautorką prezentację. A jeśli chodzi o dalsze perspektywy rozwoju, no to byłby to bardzo ciekawy temat, jeśli zebrać z całej Polski na przykład te porównania i jakby porównać przebieg tych wszystkich, żeby udoskonalić możliwe procedury w tym ciężkim schorzeniu.
Okej, super, to bardzo dziękujemy w takim razie za to rozwinięcie i również za całą prezentację. Thank you very much for this and moving forward to the next presentation. Here we got the titled presentation, Comparison of Aortic Measurements in Angiography, CT and 3D Reconstruction using VR.
Dear jury, the audience, my name is Aleksandra Skawinska and I'm representing Department of Pediatric Cardiology and Congenital Heart Defects in Zabrze. Today I'm honored to present to you our work called Comparison of Aortic Measurements in Angiography, CT and 3D Reconstructions using Virtual Reality. Coarctation of the aorta is a congenital condition, meaning it's present at birth, where part of the aorta is narrowed. This narrowing tends to happen after the left subclavian artery and before ductus arteriosus. Depending on where the aorta is actually narrowed, areas before the narrowing will experience higher blood pressure, and areas after the narrowing will experience decreased blood pressure. Coarctation can be treated either surgically or with an endovascular approach. Surgical repair is usually done in infants and young children. It involves removing the narrowed segment of the aorta and reconnecting the healthy ends or using a patch or a bypass graft. Endovascular treatment is more common in older children, adults, and cases of restenosis. Treatment options are balloon angioplasty, where a balloon is inflated to widen the narrowed segment of the aorta, or stent implantation, as you can see right here. Endovascular procedures require very precise imaging tools for proper planning. For now, angio-CT and aortography are standard imaging methods for evaluating coarctations of the aorta. Therefore, we aim to assess whether virtual reality provides reliable measurements for imagining and planning the procedures compared to these two methods. We conducted a retrospective study of 39 patients diagnosed with coarctations of the aorta between 2016 and 2024. Each patient had an elective angio-CT followed by cardiac catheterization no more than 6 months apart. 20.5% of our patients were adults and 79.5% of our patients were children. In total, we analyzed 46 angio-CT aortography study pairs. The median patient age was 10 years old and the median weight was 49 kilograms. As students, we measured aortic diameters and we used three imagining methods: aortography, angio-CT, and virtual reality reconstructions based on CT. Each measurement was taken twice by two independent investigators. As you can see right here, we measured the aorta in 4 standard locations: the sinotubular junction, proximal arch, so after the BC trunk, distal arch, so just before left subclavian artery, and of course the narrowest point of the coarctation. In aortography, the sinotubular junction is usually not being visualized. And now we present the results. As you can see, mean differences in VR were insignificantly smaller than in angio-CT. In aortography, mean differences were slightly greater than in angio-CT. And when comparing VR to aortography, mean differences were again smaller, but except at the coarctation site. These charts present all the results. On the left side, the values are shown as percentages, and on the right side, they are shown as millimeters. As you can see, in aortography, vessel diameters were greater than in angio-CT, and that is likely because angio-CT captures a static phase between systole and diasystole, while aortography, as a dynamic study, allows us to measure at peak dilation. The biggest percentage difference is observed at the coarctation site, and it's 19%. Overall, VR measurements were smaller than aortography, except this one location. And that is likely due to a very complex vascular anatomy at the site of the coarctation rather than a simple stenosis. Although this difference might seem substantial, in the very narrow anatomy of the coarctation, it translates to only millimeters. For example, a 3 millimeter diameter would differ by just 0.5 millimeters. To conclude, the dimensional differences observed in VR compared to reference imaging methods are small and insignificant. Also, VR slightly underestimated aortic dimensions, especially at the isthmus. And to sum up, VR is potentially useful in planning interventional treatment for coarctations of the aorta. Thank you for your attention.
Bardzo dziękujemy za bardzo ciekawą prezentację i przejdźmy teraz do tej dyskusji. Czy są jakieś pytania od jury?
Halo, halo?
Halo, halo, słyszymy się, tak jest?
Ja gratuluję, bo to też bardzo ciekawa praca. Mam pytanie do prezenterki, bo rozumiem, że tomografia była niebramkowana, EKG, tak?
To może ja przejmę mikrofon.
Wytłumaczę.
Tak, tomografia nie była bramkowana, to była tomografia taka, którą możemy mieć, powiedzmy, najczęściej dostępną. Chcieliśmy sprawdzić, czy takie najczęściej dostępne
Zastanawiałem się nad konkluzją, która mówiła, że tomografia pokazuje średnią jakby tą. I teraz rozumiem dlaczego.
Tak, dokładnie. Dokładnie. Chcieliśmy po prostu takie najczęściej dostępne narzędzie sprawdzić, czy będzie jakby...
Drugie pytanie do prelegentki, bo VR jest fantastyczną sprawą do mnóstwa rzeczy, w dużej mierze dydaktycznych zarówno i dla studentów, i dla lekarzy. A w Pani opinii, jaka byłaby dodatkowa wartość mierzenia VR, jeżeli nie miałoby to służyć dydaktyce? Czy w Pani opinii to ma jakąś wartość, jeżeli chodzi o precyzję na przykład?
No oczywiście przed każdym zabiegiem właśnie takim interwencyjnym jest to na pewno bardzo pomocne.
Pomiar, proszę się skupić. Pomiar. Ja zapytałem o pomiar. o pomiar. Czy warto mierzyć w VR-ze? Czy to daje jakąkolwiek dodatkową szansę, że coś będzie dokładniej zmierzone?
Tak, daje
niż
szansę.
W TK, niż w TK.
Ponieważ te różnice są bardzo małe i statystycznie nieistotne, dlatego na przykład na naszym oddziale...
Chodzi mi o Pani zrozumienie po prostu tego. Czy Pani jakby... No dobra, proszę powiedzieć.
Na naszym oddziale właśnie jest to też używane do dobierania stentów przed operacjami. Właśnie...
Wiem, Państwo to fantastycznie robią. Natomiast myślę, że warto sobie gdzieś tam w tyle głowy umieścić, że VR to jest nałożenie pewnej segmentacji na dane z tomografii, które już mamy, prawda? Więc do wyobrażenia sobie przestrzennego super, do dobrania stentu super. Macie Państwo bardzo fajne publikacje z tego planowania zabiegów, prawda? Natomiast jak gdyby samo mierzenie w VR-ze wydaje mi się, że niekoniecznie jest tak dokładne jak w tomografii. Może warto o takim zastrzeżeniu pamiętać, bo to jest ponowna reprodukcja obrazu już tomograficznego, prawda? A tak poza tym to naprawdę niezwykle ciekawa prezentacja. To, co mówię, służy tylko temu, żeby gdzieś w przyszłości, jak Pani to będzie prezentować, była Pani gotowa także na takie pytania. Ogromnie gratuluję.
Dziękujemy bardzo.
Dziękujemy.
Super, bardzo dziękujemy za prezentację. Przechodząc dalej do następnej, która jest zatytułowana and the presentation is titled The Clinical Characteristics and Mortality in Patients with Cardiogenic Shock.
Good afternoon, dear esteemed jury, ladies and gentlemen. My name is Adriana Błaszczyk and I'm presenting on behalf of our team from Student Association of First Department of Cardiology. Our paper is titled Clinical Characteristics and Mortality in Patients with Cardiogenic Shock. To begin with, let's define cardiogenic shock as a severe form of circulatory failure due to primary cardiac dysfunction. It results in inadequate tissue perfusion and organ hypoxia. The clinical criteria used to define cardiogenic shock include symptoms of heart failure, including dyspnea, shortness of breath, and fatigue. Also, the parameters including systolic blood pressure, lowered cardiac index, elevated pulmonary capillary wedge pressure, and also anuria, as well as elevated serum lactate. Clinically, patients present with signs of hypoperfusion as well as congestion, which can be explained using Forrester classification, which takes into account two factors: perfusion, is the body getting enough blood flow, and congestion, is there too much fluid in circulatory or in the lungs. And from this we derived the four profiles: warm and dry, meaning stable, as well, warm and dry, meaning stable, warm and wet, which usually presents as pulmonary edema, and cold and dry, which usually presents as hypovolemic shock. And the last one, the one with the most mortality rate, is cold and wet, and this defines our cardiogenic shock. Our retrospective study was based on academic repository of clinical cases here at Medical University of Silesia. Our study was comprised of 1,662 patients, which presented with defined diagnosis of cardiogenic shock between February 2018 and January 2025. We excluded cases which where shock was non-cardiogenic one, as well as the incomplete patient data. Our primary endpoint was in-hospital mortality. As we stratified data according to the etiology, mainly in ischemic and non-ischemic one. Our patient group had average age of, excuse me, I will take it, of 69.5 years. Out of them, 61.7% were male. Overall, mortality was strikingly high at around 67%. Comorbidities included 47% with hypertension, 35% with diabetes mellitus type 2, 20% had history of nicotine addiction, and 7% was with COPD. We observed major differences and significant statistically between comorbidities. Diabetes was more prevalent among the deceased population. Meanwhile, what is interesting, the hypertension and nicotine addiction led to to better survival, which in case of nicotine, it was in the surviving group, 30% of patients was admitting nicotine addiction. Meanwhile, in the deceased, only 50%. This suggests confounding factor, and we explored it a bit and found out that both of these groups were significantly younger. Key biomarkers showed strong connection to the mortality. Lactates as well as NT-proBNP were significantly higher in the diseased group. Meanwhile, the hemoglobin as well as the first measurement of troponin T upon admission were significantly lower. What surprised us was the value of troponin T measurements, but it later correlated to the other findings within this study. When it comes to etiology, the most common cause of cardiogenic shock was acute myocardial infarction, accounting for 60% of cases. The other causes included arrhythmias, valvular diseases, pulmonary embolism, tamponates, as well as myocarditis. We saw also a few cases, 95 cases of multifactorial causes, which were described as exacerbation of chronic heart failure. Interestingly, patients with AMI had lower mortality rate than the non-ischemic one. This may suggest that timely revascularization strategies may play significant impact in outcomes of AMI cases. It also correlates back to our findings in initial troponin T value, which were shown to be significantly lower in non-surviving patients. Our analysis showed better outcomes associated with certain invasive procedures, namely coronary angiography, as well as percutaneous coronary interventions, especially with stent placements, which is shown here in the table, were associated with better survivability. Procedures like drug-eluting balloons also showed some promise. These results reinforce our assumption that early and appropriate revascularization efforts may lead to better outcomes. To summarize, we found out, of course, that the cardiogenic shock carries a very high in-hospital mortality rate. Ischemic causes, particularly AMI, seem to respond better to intervention. Specific invasive procedures were statistically associated with higher survival rates, comorbidities, hypertension, diabetes, and nicotine use had significant association with outcomes. And to add to that, our findings require future study. It is still considered ongoing, and we plan to perform multivariate analysis to strengthen the findings and to find another connections, which for sure are here. We would, if here are of references, and I would like to thank our tutor and also to you for listening. Thank you very much for your attention. I'm happy to take any questions.
Thank you very much. Bardzo dziękujemy. Czy są jakieś pytania od szanownej komisji? To jeżeli tutaj nie ma pytań, no to zadam takie klasyczne pytanie, jaki był wkład własny Twój w tą pracę i również prezentację i jakie są Wasze plany na przyszły rozwój tego tematu?
Moim wkładem własnym, największym, no to było wykonanie praktycznie całej, oprócz opisowej, statystyki, bo opisową się zajął kolega. Oprócz tego zarówno w abstrakcie, jak i prezentacji zajęłam się przedstawieniem naszych wyników.
Okay.
A nasze plany, no to tak jak już wspomniałam w conclusion, planujemy dalej matematyczną i statystyczną interpretację tych wyników. Być może poszerzymy też to na więcej przypadków, o ile nam się uda, ponieważ tutaj widzimy, że procedury inwazyjne mogą mieć wpływ i być może uda nam się tutaj znaleźć jeszcze jakieś korelacje albo jakieś zależności, które mogą wpłynąć na dalszą interpretację.
Okej, super. To bardzo dziękuję w takim razie za prezentację. I przechodząc do przedostatniej już tutaj prezentacji, moving forward to the second of the last presentations, it's called the long-term outcome elderly patients with the heart failure treated with cardiac resynchronization therapy.
Good afternoon. My name is Paweł Wojczak. I am third-year medicine student representing the Department of Cardiology and Electrotherapy in Zabrze. And together with my colleagues, we prepared a retrospective study on long-term outcomes in elderly patients with heart failure who were treated with cardiac resynchronization therapy. Heart failure remains a significant cardiovascular concern. Main symptoms involve breathlessness after activity, feeling tired after most of the time, lightheaded or fainted, and swelling in the patient. Arrhythmias are present in the elderly patients, affecting around 10% of patients in the age above 90 years. Cardiac resynchronization therapy is one of the methods to treat irregular heart rates. Procedure involves implanting the pacemaker and usually 3 leads which connect to heart and monitor the heart rate and eventually emit pulsing to stabilize heart rate. And here's an example of the CRT device. The proportion of elderly population above 75 years is growing in Poland. However, the research on the elderly population treated with CRT remains relatively scarce. Therefore, this study aims to focus on the elderly population. Moreover, we will compare the results to the younger subjects and find the predictors of the mortality among the older patients treated with CRT. As mentioned before, this is a retrospective study which include over 1,000 patients who were treated with CRT. Patients were included in the period between 2002 and 2019 in the tertiary university hospital in Poland. A significant majority of the subjects were treated with CRT with ICD, and only 10 patients were treated with devices without defibrillator. As mentioned above, elderly patients were considered as 75 and more years. We analyzed demographics and investigated mortality factors with multivariable regression analysis. It's worth mentioning that median follow-up was over 1,117 days. Let's look at the baseline demographics. We found that a majority of the patients was male, standing for over 75%. And there was no significant difference between the two groups. Regarding New York Heart Association class, the NYHA was significantly higher in the older patients. There was no difference in terms of left ventricular and ejection fraction. And however, the left ventricular and systolic and diastolic diameter were significantly lower in the older population. Secondary prevention of sudden cardiac death was comparable between two groups. Regarding previous ICD, there was no significant difference. In terms of cardiomyopathy prevalence, in the older population, the ischemic cardiomyopathy was more prevalent, while dilated cardiomyopathy was more prevalent in the younger patients. Hypertension, along with the diabetes, were more prevalent in the older patients, and there was no significant difference in terms of atrial fibrillation between two groups. Creatine levels and NT-proBNP were significantly higher in the older patients. There was no significant difference in terms of QRS-wide. In terms of medications, there was no significant difference in terms of beta blockers or loop diuretics. However, aldosterone antagonists or AC inhibitors were significantly higher in the younger patients. In terms of all-cause mortality, we found that older patients had significantly higher mortality rate of 73.1% compared to 52.3% among the younger subjects. And here is the Kaplan-Meier curve of the survival of the heart failure patients who were aged 75 or more years. Finally, we analyzed the predictors and we found that secondary prevention of sudden cardiac death, New York Heart Association, ejection fraction before the CRT, and creatine levels before the CRT were significant predictors for the mortality among the elderly patients. To conclude, every fifth patient treated with CRT is considered, it has 75 years old or more. Most of these patients will die within the 3 years of the treatment. Lower left ventricular ejection fraction, increased creatinine levels, New York Heart Association class, and secondary prevention of SCD were identified in the multivariate regression analysis as significant predictions of mortality in these patients. However, this study is limited by retrospective design and single institution bias. Policymakers need to adjust the therapy, especially consider these factors which might influence the higher mortality among the older patients. Thank you very much.
Bardzo dziękujemy. Thank you very much for the presentation. Now moving forward to the discussion. Czy są jakieś pytania od jury odnośnie tej pracy?
Może jedno pytanie dotyczące stricte analizy pacjentów przed implantacją i po implantacji. Czy oceniali Państwo parametry echokardiograficzne? Bo wiemy, iż u pacjentów, co prawda tutaj porównujemy, że u pacjentów młodszych ta śmiertelność była mniejsza, u pacjentów starszych zwiększona, natomiast należy pamiętać, że chociażby przewlekłe migotanie przedsionków, inne schorzenia, już nie wdarzając się w szczegóły sercowe, predysponują do zarówno dilatacji przedsionków, jak i niewydolności komór. Stąd czy ten parametr podlegał ocenie, czy nie był jakoś szczególnie uwzględniany przez Państwa?
Ten akurat parametrów tak bardzo nie analizowaliśmy w naszym badaniu.
Dziękuję.
Dobrze, to jeżeli nie ma jeszcze pytań, to mamy pytanie takie, jaki był wkład pracy Twój w całą tą pracę i jaka jest perspektywa przyszłości rozwoju tego tematu u Was?
No to byliśmy udział w tworzeniu projektu tego. Ja zajmowałem się zbieraniem danych, ekstrakcją i potem analizą tych danych oraz przygotowaniem tej prezentacji i wygłoszeniem jej teraz.
Okej, super, to bardzo dziękuję, gratulacje. Z tego co widziałem, to już wszystkie prezentacje pojawiły się. Tutaj już zobaczę. Na formularzu mam jeszcze prezentację Long Term Outcomes in Heart Failure Patients Undergoing CRT with versus without remote monitoring. Aha, to była ten. Okay, dobra, rozumiem, dobra. Okay, so thank you very much, and going forward, this was the last presentation as was shown. Thank you very much for your apprenticeship, welcome, and we are supposed to invite you to the closing ceremony, which will take place tomorrow at 5:00 p.m. And also at 9 p.m. Tomorrow we'll take the party after party of the SIMC in DSO. Thank you very much for your coming. Thank you. Bardzo dziękujemy również całej jury. Dziękujemy panu profesorowi Grzegorzu Smolce za tutaj możliwość, za poświęcony czas i za całokształt tutaj bycia w jury. Dziękujemy również panu doktorowi Sebastianowi Krychowi oraz pani doktor Marii Stec. Bardzo dziękujemy i życzymy wam wszystkiego dobrego. Dziękuję bardzo. Do widzenia.